All right, we are going to go through all the muscles of the hip. There are a lot of them, but a lot of them are shared between the hip and the knee. And so when we get to the knee, we will be going over relatively few. So don't let the sheer number of them freak you out. I do want you to know the origin, insertion, action, and innervation of all of the muscles that we talk about. And so it's a lot of them. So start getting out those flashcards and studying those muscles. It also helps to look at the pictures in the book, look at the pictures in the trail guide, and palpate the muscles on yourself and your friends and family and your classmates when you get to the lab. On page 247 in the Mansfield text, there is a nice little, two little tables that I like. One of them is the summary of the hip kinematics. It talks about all of the motions at the hip: flexion, extension, ab and adduction, internal, external rotation, the axis of rotation and the plane of the motion. And it talks about the normal range of motion in degrees, which I don't expect you to know, but just start getting familiar with that. We'll talk more about that in the summer when we learn goniometry. So for the learning objectives, I want you to be able to identify the primary muscles that are responsible for moving the hip. So we refer to them usually as prime movers. So the prime movers for all of the standard hip motions: flexion, extension, ab and adduction, and internal and external rotation. I want you to be able to identify the relationships of the muscles to each other using anatomical terms. So is the muscle deep or superficial to another muscle? Is it superior or inferior, etc. The innervation, the summary of the innervation of the hip muscles is also on page 247 in the text. And I like things in chart form. I just like charts, they make sense. And it's a good way, a different way to look at it to memorize than just memorizing lists. In your lab manual, you also have the hip muscle list with all the actions, innervations, origins, and insertions that I want you to know. So the first action is flexion and extension, right? Or first two actions. So our primary hip flexors are iliopsoas, rectus femoris, sartorius, and the tensor fasciae lata. The sartorius and the tensor fasciae lata are not, they're like the minor players, and the iliopsoas and the rectus femoris are the major players. Interestingly enough, most of the hip adductor muscles also flex the hip, and we'll talk about line of pull and how they have a line of pull for flexion. So sometimes you look at the lists of muscles and they have very detailed origins and insertions, and I don't expect you to know an extreme level of detail, like, oh, the superior lateral portion of the greater trochanter, but just the general origin and insertion, so you can assess the line of pull and you can know what the action is. So the psoas major has a proximal attachment or origin on the transverse processes and lateral bodies of T12 through L5. So that is a very broad attachment up at the top there. You can sort of think of the iliopsoas. It's mostly, the psoas portion is mostly a fusiform muscle, but because it has such broad attachments, it's almost like a triangular muscle. Broad superior attachment down to a small inferior attachment. The distal attachment or the insertion is the lesser trochanter of the femur. It joins together in a common tendon with the iliacus. The iliacus has a proximal attachment on the iliac fossa and the inner lip of the iliac crest, and a little bit on the sacrum. And it has that common tendon with the psoas major for the lesser trochanter of the femur. The psoas minor is an itty bitty little muscle that doesn't really have a line of pull for hip flexion. It attaches to the anterior ring of the pelvis on the pubic crest. And it's more of a stabilizer than anything. But the psoas major and the iliacus are hip flexors. That's their main job. They're innervated by the femoral nerve, and we will see that all of the hip flexors are innervated by the femoral nerve. So if something performs hip flexion, it's a good guess that it's innervated by the femoral nerve. The rectus femoris is our other major hip flexor. It is part of the quadriceps group. It's the most superficial of the quadriceps. Its proximal attachment is the anterior inferior iliac spine, and its distal attachment, along with the other three quadriceps, is the tibial tuberosity. It is the only one of the quadriceps that crosses the hip and the knee. All the other ones just cross the knee. It does hip flexion and knee extension, and it's innervated by the femoral nerve like all the other muscles that do hip flexion. The sartorius is an interesting muscle. It's the longest muscle in the body. Its origin, its proximal attachment is the anterior superior iliac spine, and the distal attachment is on the proximal medial surface of the tibia, the anteromedial surface of the tibia. So it shares a common tendon with two other muscles, the gracilis and the semitendinosus. And that common attachment at the anteromedial aspect of the proximal tibia is called the pes anserinus. So, which is Latin for goose foot. Don't ask. I imagine people knew what goose feet looked like back then, and somebody said, hey, that looks like a goose's foot. But anyway, there we go, proximal medial surface of the tibia. The sartorius, because it mostly goes superior to inferior and it runs anterior to the medial lateral axis, it does hip flexion. But it has a slightly oblique line running lateral to medial, so it does a little bit of hip abduction, a little bit of hip external rotation. It assists in knee flexion, and there's a little internal rotation in the terminal part of knee extension, and it assists in that too. But it is one of the primary hip flexors. You can think of the major action of the sartorius is the combined action of putting your foot on your opposite knee or sitting cross-legged. So hip flexion, abduction, and external rotation. So sartorius is the root of the word is the Latin word for tailor, and tailors used to sit cross-legged. That's where it comes from. Some people have trouble remembering that. But if you remember, the sartorius is the longest, most superficial muscle in the thigh, and it's the longest muscle in the body. We think of it as a hip flexor, even though it has those other actions, and it's innervated by the femoral nerve. The tensor fasciolata is, some people think of the mnemonic for that is you have a latte and you're sitting it on your hip. I don't know, that doesn't really come to my mind, but anyway, tensor fasciolata, I think of it as it puts tension on the fascia of the IT band. So that's how I remember it. Its proximal attachment, its origin is the outer surface of the iliac crest, just posterior to the ASIS. So you have if you think of the attachments in relationship to each other, the sartorius attachment is on the ASIS. The tensor fasciolata attachment is just posterior to that. So it's just in between the sartorius and the gluteus medius. The distal attachment is the proximal 1/3 of the iliotibial band. And the iliotibial band then goes down to attach on the tibia. So its name gives you exactly where it goes to and from. It goes from the ilium to the tibia. The tensor fasciolata does have a line of pull for hip flexion because it's anterior to the medial lateral axis. Because it runs a little bit lateral to medial, it has a slight line of pull for hip abduction, and the anterior fibers have a slight line of pull for hip internal rotation. But its primary motion is to put tension on the IT band. It's innervated by the superior gluteal nerve, which also innervates the gluteus medius and the gluteus minimus right in that same area. So I think of them as being like neighbors that share the same Wi-Fi connection. So they share that same superior gluteal nerve with the gluteus medius and gluteus minimus. So those are really the ones that we think of as our primary hip flexors, even though we know that adductors do tend to have a line of pull for hip flexion, and we'll talk about that when we get to the adductors. The next group that we're going to talk about is the hip extensors. So the hip extensors, the primary ones are the hamstrings, the semitendinosus, semimembranosus, and the long head of the biceps femoris, and the gluteus maximus, and the extensor head of the adductor magnus. So the adductor magnus is a huge muscle, and even though it's part of the adductor group, it has an extensor head and it has an adductor head, and each one has an innervation that matches the group, which is kind of nice. Our hip extensors are mostly innervated by the sciatic nerve, except the gluteus maximus has its own. I figure it's a big muscle, it needs its own connection. So its proximal attachment, it's a rhomboidal muscle, so it has a broad proximal attachment and a broad distal attachment, and it's roughly square, so it's a quadrilateral shape. The proximal attachment is the posterior ilium sacrum and really a lot of the ligaments in the neighborhood in the coccyx. So big, wide proximal attachment, big, wide distal attachment along the iliotibial band and the gluteal tuberosity of the femur. Remember, that's the one leg of the Y. The other leg is the pectineal line, and then they make a Y with the linea aspera. So gluteus maximus, its reason for living is hip extension and external rotation. It has that line of pull that's posterior to the medial lateral axis, giving it that line of pull for hip extension. It also has a slight medial to lateral oblique line. When you look at the muscle fibers, they run obliquely, and that gives you your line of pull for external rotation. The gluteus maximus also is part of the group that functions in the force couple for posterior pelvic tilt, and we will talk about that in the last lecture of the hip section. It's innervated by the inferior gluteal nerve. So if you put your hands on your iliac crests, the gluteus medius runs along the iliac crest and the gluteus maximus is a little bit inferior to that. So the gluteus medius gets the superior gluteal nerve and the gluteus maximus gets the inferior gluteal nerve. The other hip extensors are the 3 two-joint hamstrings, semitendinosus, semimembranosus, and the long head of the biceps femoris. All of them have their origin, their proximal attachment on the ischial tuberosity. The distal attachment of each of the muscles is a little bit different. So the semitendinosus shares that pes anserinus at the anteromedial aspect of the proximal tibia with the sartorius and the gracilis. So its origin is the ischial tuberosity, its insertion is the pes anserine. Its actions are hip extension because it's posterior to the medial lateral axis. It's part of the group that works in posterior pelvic tilt. It crosses the back of the knee as well and performs knee flexion. And it's one of the group that works on knee internal rotation. So we'll talk about that in the knee chapter. It's innervated by the sciatic nerve, and it's the tibial part of the sciatic nerve. So the biceps femoris, the long head, is the on the lateral side of the hamstrings. The semitendinosus is on the medial side. It also attaches to the ischial tuberosity, but its distal attachment is the head of the fibula on the lateral side. It also has the actions of hip extension. It works together with the others in the posterior pelvic tilt. It also does knee flexion, And because it's on the lateral side, it works in knee external rotation. And it's also innervated by the sciatic nerve, the tibial part of the sciatic nerve. The semimembranosus is the deeper medial hamstring. That semitendinosus is more superficial. One of the mnemonics that I heard for remembering that is membranosus and tendinosus. The membranosus is sort of around the tendinosus, and so it's mom and tot, membranosus and tendinosus. The mom has its arms around the tot, if you want to think of it that way. So lots of different mnemonics out there for remembering things. So the semimembranosus also has its origin at the ischial tuberosity. Its distal attachment is the medial condyle of the posterior aspect of the tibia. So you can think of the around the top of the tibia and fibula is a lot of different attachments for the hamstrings. It runs posterior to the medial lateral axis, so it has a line of pull for extension. It also works on the group on posterior pelvic tilt. It crosses the knee posteriorly, and so it has a line of pull for knee flexion, and it's on the medial side, so it has a line of pull for internal knee rotation. It's also innervated by the tibial part of the sciatic nerve, just like the other hamstrings. So the hip abductors are, you can imagine they have a line of pull that goes from medial to lateral, or lateral to medial for abduction and adduction. So the main hip abductors are the gluteus medius and the gluteus minimus, but there are a lot of other muscles that moonlight in hip abduction. So the sartorius is one of them. It has a slight line of pull for hip abduction. The gluteus medius and the gluteus minimus are both innervated by the superior gluteal nerve. So gluteus medius, gluteus minimus, and tensor fasciolata all share that same Wi-Fi connection. The piriformis and sartorius also have a little bit of a line of pull for hip abduction, and we'll talk about the piriformis with its group. The proximal attachment origin of the gluteus medius is the outer surface of the ilium. And you can palpate the origin and the insertion of the gluteus medius. So the distal attachment is the greater trochanter. So obvious line of pull for abduction. So it's lateral to the anterior posterior axis, and the it's a triangular muscle with a broad origin and a small insertion. Because it has some fibers that run a little bit obliquely, it can also do a little bit of internal or external hip rotation, but its primary action is hip abduction. It's a super important muscle for gait stability. We work on it a ton in physical therapy. So gluteus medius and quadriceps are kind of two of the muscle groups that we work on the most in physical therapy. If someone has weak hips, it upsets their gait. If someone has tight hips, it upsets their gait. So gluteus medius, we're always working on the old gluteus medius. Gluteus minimus is the gluteus medius's little helper. Its proximal attachment is the outer surface of the ilium, a little bit inferior to the gluteus medius, and it's deep to the gluteus medius. Its distal attachment is the greater trochanter, just like the gluteus medius. It does hip abduction, and it has a little bit of a line of pull for internal rotation. It's innervated by the superior gluteal nerve, which it shares with the gluteus medius and the tensor fasciolata. So we'll talk about the individual muscles if they have a line of pull for abduction, but gluteus medius and gluteus minimus are your primary abductors. When those are weak, that causes what we call Trendelenburg sign or Trendelenburg gait. And there is a video in the Canvas module you can look at demonstrating Trendelenburg gait. and we'll talk in detail about it in the functional considerations part of the hip lecture. So on to the hip adductors. And like I said earlier, a lot of the hip abductors have a line of pull for hip flexion as well because of where they're attached. So the first hip abductor that we're going to talk about is the pectineus. Its proximal attachment is, surprise, surprise, the pectineal line on the superior pubic ramus. So its two attachments, its origin and insertion, are both pectineal line, but there's a pectineal line on the superior ramus and a pectineal line on this posterior surface of the femur. So because it goes from anterior on the pelvis to posterior on the femur, that gives it its line of pull for hip flexion. Because it runs a little bit obliquely from medial to lateral, that gives it its line of pull for hip adduction. So interestingly enough, most of the muscles with adductor in their name are innervated by the obturator nerve. The pectineus has a little bit of innervation from the femoral nerve and a little bit from the obturator nerve. So you can think of the femoral nerve as for its hip flexion function, and the obturator nerve is for its adduction function. That's just a good way to remember it. Okay, so now we're going to talk about the three adductors that have the word adductor in their name. So it's adductor longus, brevis, and magnus. So the adductor longus, its proximal attachment is on the anterior surface of the body of the pubis. Its distal attachment is the middle third of the linea aspera of the femur. So it also runs from anterior on the pelvis to posterior on the femur, giving it a line of pull for hip flexion. And it has a medial to lateral oblique line, giving it the line of pull for adduction. And it's innervated by the obturator nerve, like all the other ones with adductor in their name. The adductor brevis attaches from the anterior surface of the inferior pubic ramus. So it's a little bit inferior to the pectineus and the adductor longus. And its distal attachment is the proximal 1/3 of the linea aspera of the femur. So it has that anterior to posterior line of pull, and it can do hip flexion. And then it has the medial to lateral line of pull to do hip adduction, and it's innervated by the obturator nerve. So I hope you're getting the idea of how line of pull determines what motion the muscle can do. So the adductor magnus is huge. It's the deepest and most massive of the adductors. It fills in all the space in between your femur and the outside, the inner portion of your thigh. So it's huge. There is an opening, or it's called the hiatus, the adductor hiatus, in the distal attachment between the linea aspera and the adductor tubercle. And that is an opening that the femoral artery and vein pass through. After the femoral artery and vein pass through the adductor hiatus, their names change to the popliteal artery and vein. So that happens a lot where after a structure passes through an opening, its name changes. We will encounter that a lot in anatomy. The adductor magnus has an extensor head and an adductor head. And like you would expect, the extensor head is innervated by the tibial portion of the sciatic nerve, and the adductor head is innervated by the obturator nerve. So the extensor head of the adductor magnus is the posterior head. So if it's running posterior to the medial lateral axis, it does hip extension. Makes sense, right? Its proximal attachment is the ischial tuberosity along with the hamstrings. Its distal attachment is the adductor tubercle on the distal femur. It does hip extension and hip adduction, and it's innervated by the sciatic nerve, the tibial part of the sciatic nerve. The adductor head, which is the anterior head of the adductor magnus, its proximal attachment is on the ischial ramus. So a little bit anterior to the extensor head, and its distal attachment is the entire linea aspera of the femur. So it attaches all along the linea aspera. That gives it its line of pull for hip flexion, and then it has that medial to lateral line of pull for hip adduction, and it's innervated by the obturator nerve. So you can see the adductor magnus, it's huge in hip function. It can do extension, it can do flexion, it can do adduction. It is also a very commonly strained muscle when you're doing things like jumping and sprinting, because it has to switch between its functions pretty rapidly. And so when you get a groin pull, it's usually the adductor magnus that's affected. Interesting, right? So the gracilis is the most medial adductor muscle. It has a pretty straight line of pull. So just barely oblique from medial to lateral, giving it its action of hip adduction. But it also goes from the body and inferior ramus of the pubis, and it attaches to the proximal medial aspect of the tibia at the pes anserinus. So it shares that attachment with the semitendinosus and the sartorius. So it performs hip adduction, hip flexion. It has a little bit of a line of pull for knee flexion because of that posterior to anterior excursion, and a little bit of a line of pull for knee internal rotation. As a hip adductor, it is innervated by the obturator nerve. It primarily at the knee, it works on medial stabilization of the knee, as do the sartorius and the semitendinosus, but it has those other lines of pull that it can participate in those other actions. So deep to the gluteus maximus, we have 6 short external rotator muscles. And I'm not going to expect you to know the origin and insertion of each individual one, but just know that most of them originate on the posterior sacrum, ischium, and pubis, and they insert somewhere on the greater trochanter area. So they course medial to lateral, and they perform hip external rotation. So when you look at the lines of pull, when you look at the fiber directions, most of the muscles fiber directions are going this way, and you can see that when the muscle shortens, it's going to pull the greater trochanter posteriorly in that external rotation. So the piriformis, basically, if you look at them, I'm going to erase my scribbling. The piriformis is the most superior, then the gemellus superior, then the obturator externus, then the gemellus inferior, then the obturator internus, then the quadratus femoris, if you go in that order. But really what I want you to know is that there are 6 of them. They mostly do external rotation of the hip. The piriformis is the only one that runs superficial to the sciatic nerve. So if the piriformis is too tight, it can put pressure on the sciatic nerve. All the rest of them are deep to the sciatic nerve. That's all you need to know about them, is they do hip external rotation. They mostly span the hip horizontally. They are really important in terms of stabilization in walking. And you'll see a lot of times after someone has had a stroke, a CVA, they have difficulty coordinating their external rotator muscles, and we work on that a lot in therapy. So I don't expect you to know the details on these guys, but just their basic function and location. So the hip really has no primary internal rotators, but several secondary internal rotators that help change direction and balance the force of other flexor muscles. So the anterior fibers of the gluteus medius can do a little bit of internal rotation, and the gluteus minimus. The tensor fasciolata can do a little bit. The adductor longus can do a little bit, and the adductor brevis can also do a little bit. So it's not their main job, but they can function a little bit in hip internal rotation.